At least some of the accumulated gray hair you've grown in the last couple of years, my guess is due to electronic health records. It has been a tremendous headache, but we also have some interesting news, and it's from a huge analysis of the NCDR database. The Association of Electronic Health Record Use with Acute MI Quality of Care and Outcomes results from the NCDR. I am with Sandeep R, MD, MPH. This is your second time here. Congratulations, and thank you for doing this again. University of Texas Southwestern Medical Center, and Jonathan R. Enriquez, MD, University of Missouri, Kansas City. Let's start first with, what did you do? This is a huge analysis.
We found that in our study, the use of the electronic health record has risen to exceedingly high levels, with over 99% of hospitals in the ACTION registry having either partial or full EHR at this time. We found that the EHR is associated with increased patient safety. We found that significantly lower rates of heparin overdosing were seen with the use of the electronic health record. After adjustment for potential confounders, we saw that the EHR was associated with approximately 20% reduction in mortality and major bleeding, and also after adjustment we found that the EHR was associated with the provision of defect-free care, with about 40 to 50% more likely compared to those centers without the EHR.
I mean, this has to be good news for people who've been struggling trying to get EHRs up and running, because we have in the past not had great data to support the fact, is this really helping? It really does seem to be helping.
Well, it does. So, one of the things I think that's frustrating is that people, if you want to get doctors to change their practice, that's financial incentives drive much of that. Yeah. But what really, makes us happy as physicians is that we're taking better care of patients. So it's nice to know that in this case they align the things that the hospitals and doctors are doing in order to be compliant with government-driven agendas. In addition, allows us to take better care, and there's certainly that association that John described.
I mean, are there some things that you might be able to find through the NCDR database? For example, one of the interviews we did here was talking about the fact that some 7% of patients who have a Class 1 indication recommendation for aspirin just don't get it before PCI. Could an electronic health record help in something like that and keep that mistake from happening?
Yeah, absolutely. That's the perfect kind of thing, role for the electronic health record. So what you can do is you can set flags to trigger when patients meet certain criteria, that doctors can get a real-time pop-up that says your patient should be on an aspirin and isn't. The challenge is actually not designing more of these pop-ups, it's actually tuning them better to clinical practice, because what we see, and I think a lot of your viewers may see, is in practice you see 15 or 20 of these pop-ups, and they're about a bunch of things that are probably less clinically relevant. So I think that what we need is a better interface between clinicians and the IT folks who are helping design the back end of the system.
One of the things I didn't ask is, how large of a population did you look at?
So we were left with a set of over 120,000 patients from over 440 sites around the country. So
that's a great use of our large NCDR database.
It is, yeah. The NCDR database is very robust and can provide a lot of opportunities to explore the areas for improvement in quality and care and outcomes in many domains of cardiovascular care.
Well, we have a wide variety of NCDR papers that are being presented at the American Heart Association meeting that we're summarizing in CardioSource World News. So please check out our next couple of issues of CSWN. I'm Executive Editor Rick McGuire.